diabetic coma, bleeding, right? And even adrenal crisis, thyroid crisis, cardiac arrest, foreign body, aspiration, epilepsy, asthmatic attack, allergy, anaphylaxis, and many, many more conditions we'll be discussing. Okay, so dear students, so whenever a patient goes into synco, so you know that what needs to be done. First and foremost, the patient should be reclined, right? And then the heart and the brain should be at the same level. Basically, the brain should be at a lower level. The leg should be elevated so that the pumping of the blood towards the brain takes place. So now, whenever there is synco, now two conditions can happen. Either the patient can become unconscious or patient is conscious, but little giddiness he is feeling. So if a patient is feeling giddiness but conscious, then spirit of ammonia can be given. So spirit of ammonia, it is a respiratory stimulant. You can soak it in a cotton, bring it towards the nose of the patient. It acts as a respiratory stimulant, which is a very, very important MCQ. And then you can give even the glucose powder. Okay, the glucose powder, you can give that. And then if the patient is unconscious, that is comatose patient, completely lying, then what will you do? You will try to wake him up. He is not getting up. So this glucose powder, spirit of ammonia, may not be acting much at this time because the patient is completely unconscious. So in this condition, what you will be doing is you will be giving IV dextrose injection. This is the carbohydrate. You are going to infuse dextrose injection. Okay, sucrose, fructose, maltose, you have read that. So IV dextrose injection, 25% IV you will give. So the first condition we are discussing, that is syncope. Patient conscious, spirit of ammonia, glucose powder and water. Unconscious, you are going to give IV dextrose injection. That is 25%. Right. So then once you give IV dextrose injection, patient will be fine. So this is the takeaway from the syncope. Right. Other things, the mechanism, what happens, peripheral pooling of the blood, why it happens, what we'll discuss in a further way. Now, the next condition is angina pectoris. So you're doing a case, suddenly the patient develops chest pain. Okay. So it's not a heart attack, but there is a pain in the chest. So what you are going to do, immediately if the patient complains of chest pain, put sublingual nitrate tablet below the mouth. So if you put the sublingual nitrate tablet below the tongue, below the mouth means below the tongue. So once you keep it below the tongue and wait for some time, and if the pain gets relieved, so the patient complained of chest pain, you gave sublingual nitrate tablet, pain relieved. So that was angina pectoris. So based on the condition of the patient, better not to continue the procedure, stop the procedure, and the patient should see his cardiologist, and stress-free he should be. Patient was developing angina pectoris, you gave sublingual nitrate tablet, you tried for 3 times for a period of 5 to 10 minutes, you tried 3 times, and still the patient is still complaining of chest pain. So the pain is not relieved by sublingual nitrate tablet. Then what to do? Then what are the condition is? Then it may not be angina pectoris. It could be any of these 3 conditions. So this is like a differential diagnosis, how you study in oral medicine. So it could be either myocardial infarction, it could be aortic aneurysm, it could be gastric pain, just gas problem, gastritis. Because of gas problem, he is developing an angina pectoris. Chest pain is there. Just a Rantac injection will solve that problem. But we are thinking it could be heart attack or angina pectoris. So any of these 3 could be. So this is a systematic method how you should go. Angina pectoris, give sublingual nitrate, pain relieved. That was angina pectoris. Pain is relieved, patient is fine. Not relieved, it could be any of these 3. So we need to deal with these 3. So first one, myocardial infarction. So what is myocardial infarction? There is excessive pain in the chest. The patient will be profusely sweating and the pain will be radiating to the left arm. And even if you give sublingual nitrate tablet, which we have just discussed, it's not going to help the patient. So what you need to do? You do not move the patient. Call for or activate EMS, emergency medical system, right? Call for help. Give oxygen to the patient. morphine 5 mg slow IV can be given and shift the patient to the hospital as soon as possible. So myocardial infarction, you have to give oxygen and morphine. Other alternatives I will be discussing at level 2. So this is the basic thing what I am talking. So step by step, you should learn this. Next, so angina pectoris was there. Pain is not relieved by sublingual nitrate. So first was myocardial infarction. You understood what needs to be done. Now, the second possibility could be epigastric pain because of the gas problem. Patient may be having angina pectoris. So where could be the problem? So it is basically at the epigastric region. You can see here the circled one. This is the region where there will be pain across the chest. So the drug of choice is ranitidine, which after every extraction we give Rantac. So this is the ranitidine injection which will solve this problem. Next condition, hyperventilation. So hyperventilation is a condition where the patient is not able to breathe properly. And you may think that the oxygen is the problem. Oxygen supply is not there. But actually it is not the oxygen. It is the carbon dioxide patient needs to be given. Right. So there is a little imbalance between the partial pressure of oxygen and the carbon dioxide. Details we'll discuss again. So here in hyperventilation, give carbon dioxide and not oxygen. How are you going to do that? So take a polythene or take a paper, make a cone and keep it on the patient's mouth. So the patient, when he exhales carbon dioxide, same carbon dioxide patient will be inhaling. So this is a condition where you can give this. So like this, a funnels can be made. So hyperventilation, give carbon dioxide. Now, next condition, patient is diabetic. Patient is diabetic and he collapsed. Now you don't know whether the patient is having hyperglycemia or hypoglycemia. Diabetes are two types, right? Hyper and hypo. You don't know any of them. Patient just collapsed. So you're checking his pocket. You didn't get any tablets to know whether he is under hyper or hypoglycemic condition. Whatever, hyper or hypo, patient just collapsed. You give IV dextrose 25% injection. So this is the same IV dextrose which was given during syncope. I hope you remember. So once you give IV dextrose injection, irrespective of hypo or hyperglycemic condition, so once you give IV dextrose injection, two things can happen. Either the patient will recover or the patient will not recover. Any of this only can happen. If the patient recovers after giving IV 25% dextrose injection, then that was hypoglycemic because this dextrose is carbohydrate. You gave carbohydrate. There was hypoglycemic condition. So you gave the carbohydrate, you gave the food. So then patient recovered. So it's very simple. Give dextrose injection, patient recovers, it is hypoglycemic, and in hypoglycemic conditions, if necessary, you can give glucagon injection. So it's very clear where you have to give glucagon in hypoglycemia. Similarly, patient collapsed, he's diabetic, you gave dextrose, IV dextrose, 25%, patient is not recovering. That means the patient is suffering from hyperglycemic coma. Hyper. So give insulin injection. So I hope the flowchart is very clear now. Where to give glucagon and where to give insulin, it's crystal clear. Right? So please learn this flowchart properly. Next condition, if the patient is having severe bleeding problem. Now, if the bleeding is too much, then you have to give local hemostatic agents. So ethamsulate injections can be given. Ethamsulate injections can be given. Surgicel, gel foam, vitamin K supplements, if the clotting factors are not proper, all the supplements can also be given to them. Next condition, adrenal crisis. So adrenal crisis where the patients, he's not able to make the hormones properly, right? So the cortisol hormones is not being properly done. So he's suffering from stress. A lot of stress will be there in this. So these patients who are suffering from adrenal crisis, they will be taking a supplement of steroids. So whatever steroids they are taking, you should double the dose during or before any procedure. So before any procedure, you have to double the dose. The patient is on steroid and patient may go into a state of hypotensive shock. So prophylactically, You know that patient's case history tells that adrenal crisis is there. So give steroids. So steroids, whatever patient is taking, same dose you just double it. So that means one dose is for his normal survival, the other dose is for the procedure what you are going to do, so that it will take care of the stress. So I hope you're very clear with this concept. Next condition, thyroid crisis. So the thyroid crisis, there will be palpitations and tremors, right? Heartbeat will be very high, palpitation, tachycardia will be there. So heart will go for a 6er, means there is a severe tachycardia. So here, when there is thyroid problem, thyroid crisis, do not mix adrenaline in local anesthesia. You have to give plain LA, not with adrenaline. Okay? So already there is palpitations, there is tachycardia, and you give adrenaline, right? So vasoconstrictor effect, more it will happen. So other drugs, what you can give it, chlorpromazine, carbamazole, dexamethasone. These are the other things what you need to give. When a patient gets cardiac arrest, so make the patient lie down flat, right? And then if there is no pulse, check for pulse, respiration and heartbeat. If all the three are missing, then you should start CPR. For CPR, you have to straighten the neck, tilt the head, right? And then that is called head tilt position, like this, what you're seeing on your screen. Then chin lift, jaw thrust. Open the jaw, press on the back side, so the mouth will open because patient is unconscious, right? So he will not be voluntarily opening. Then at the intermammillary line, around the area of nipples, on imaginary line you can imagine, and then towards the left side you can, over the heart, between the second costal ridge, second intercostal ridge, that area, you can put your thumb and then compression scale will be given. 30:2, 15:1 rescuer. So those concepts you should learn more in detail for CPR. Then what you can give is adrenaline injections can be given 1:1000, right? Because the heart may not be responding. So adrenaline injection will be good to stimulate the heart. And hydrocortisone injection 100 mg IV also can be given in conditions where the patient's heart is not responding. So to stimulate the heart, this adrenaline hydrocortisone can be given. Along with that, sodium bicarbonate. At level 2, we'll be discussing what are these drugs. Sodium bicarbonate, ECG monitoring, PQRS, all the intervals needs to be checked. Whether there is depolarization, repolarization, atrial defect, septum ventricular defect, septum defect, all those things you need to find out in ECG. Then you have to give oxygen and the emergency medical team should be activated. The next medical emergency condition which can come as foreign body aspiration. Something patient would have swallowed and it would have got stuck. So in these conditions, you have to do perform a maneuver called as Helmig's maneuver. So here no drugs, only action. So what you have to do is back of the patient, let the patient little tilt, and then on back side with vigorously give 5 blows. And then here at this area, the epigastric region, make a fist and then give 5 abdominal thrust. So by doing this, whatever foreign body was aspirated, chances are there when you're hitting, when you're giving blows, it will come out. Next condition, epilepsy. So when you're doing a dental procedure, suddenly patient gets that aura and he gets epileptic attack. Immediately stop the procedure and patient will bite his tongue that moment. So you need to protect his tongue, take out all the equipments, whatever you're doing, scaling, filling, whatever you're doing, take it out, put a bite guard, very important. And lot of the froth will be coming out. So you can do suction also. And to calm the patient, you can give diazepam. So diazepam to calm the patient. Right. Now on a common place or a common ground where there's not dental chair, bite guard, suction, these are not available, then a handkerchief or any piece of cloth can be kept between the teeth. So which will make sure the teeth are not biting and the tongue is not getting affected. Next condition, asthma. So whenever an asthma develops, see, it's a general tendency, the patient is not well, we tell them to lie down. In asthma, it's a breathing, oxygen is not going properly, right? Breathing difficulty is there. Don't make the patient lie down, but the patient should be upright condition. Patient must be in sitting position. Never make the patient lie down. And then Derifylin, hydrocortisone, and salbutamol inhaler needs to be given. So you should note all these options what are available. In case of allergy or anaphylaxis, anything happened suddenly, drug allergy happened. So you need to be very fast in anaphylactic reactions. So the options are hydrocortisone, steroids, which will help you to solve the problem, ephedrine, chlorpheniramine, maleate. So these are all injections. You can't give a tablet and let it undergo the first pass metabolism and then do its action, delayed action. You can't. You have to do it very fast. So 100% bioavailability is there if there is a parenteral route of drug administration. So that is your IV injections. Then if a patient is having severe bradycardia, heart rate is going down, what you have to do is load a dose of atropine and directly intracardiac injection also can be given. If heart rate is less than 40, then you can give atropine injections. You did the procedure, severe pain. So that means your opioid analgesics is not helping. Opioid analgesics is not helping. Then you have to go for, your non-opioid analgesics or non-steroidal anti-inflammatory drugs are not working. Then you have to go for opioid analgesics. So you can give tramadol and diclofenac sodium injections, right? So that is severe post-operative pain. So dear friends, this was the level 1, what I told you, where the basics of everything you have learned. Now I will be going towards the level 2, right? So that was just quick review of what we will be discussing in detail. So dear students, again I repeat, medical emergencies you should know in and out. Okay, there is no excuse for this. For every drug there could be an allergy. You have to find an alternative for it. You should know whether IM, IV, what is the pediatric dose and what is the adult dose. So I will be displaying a lot of charts now where all values will be there and all doses will be there. So whenever you are reading this at your leisure time, pause the video, take a screenshot, learn it properly. Okay. So as usual, all these conditions I will be discussing one by one. So medical emergencies, dear students, friends, doctors, you know that it can happen anywhere at any time. So first thing you should know is an emergency kit. In your clinics, there should be an emergency kit. So this emergency kit, or you call it like a module, is based on doctor's degree of training. You made a kit, but you don't know how to give a medicine. What is the use of just putting a museum in your clinic where you don't know what is IM and what is IV? You have read everything, but you don't know. So that is not good. So you should be aware and you should practice it also. So you need to learn that. So module 1 is just basic emergency kit where critical drugs will be there and equipments will be there. Module 2, non-critical drugs. 3, advanced care life support drugs will be kept. And module 4, antidotal drugs. If any reaction happens, the antidote of that is given. So there are various modules step by step where the emergency drugs power increases, the potential, the scenario completely transforms. So now emergency kit, the kit what you have in your clinics. So there could be critical drugs and equipments also. So basically emergency, so it should be all injectables, right? So these are the ones which I am going to tell you now, the main drug and the alternative also, if it is available. So if there is an allergy or anaphylaxis, the first one what you're saying, allergy. So the main drug what you can give is adrenaline injection. If there is an allergy, adrenaline injection, 1:1,000 is for cardiac arrest, 1:10,000 dilution is for anaphylaxis. Please understand what I told. Adrenaline is given for cardiac arrest also, 1:1,000 dilution. And if it is for allergy, 1:10,000 is the dilution. So allergy, anaphylactic reaction, adrenaline can be given and there is no alternative to this. And then if there is allergy or histamine blockers can be given, The drug of choice will be chlorpheniramine, which I have already given. It is an alternative for your normal histamine blockers. So option A is histamine blockers. Option B, alternative, is chlorpheniramine. And then you have got non-injectable also, oxygen, vasodilators. So vasodilators like nitroglycerins you can give. If it is not, then nitrostat sublingual tablets can be given. And then bronchodilators, anti-hypoglycemic drugs, inhibitors of platelet aggregation. So these are all the alternatives for that. So you should learn these are the drugs which comes in the critical drugs and equipment module 1 kit. So in this you have vasodilator, bronchodilator, anti-hypoglycemic drug, platelet aggregation inhibitors, allergy inhibitors or histamine blockers, and allergy anaphylaxis, the antidote for that. Then in the same kit, you have got oxygen delivery system, AED, very important, defibrillators, suction tips, tourniquets, and Magill's intubation forceps are there. If anything is stuck, you can take out with this. So you can see this alternative is also displayed here. You should learn it at ease. Okay. Then next is the module 2. Next is the module 2. Just a second. One second. Okay. So what I was discussing was module 1. So I think some slides were not changing. No problem. I'm just giving you the view of it. So this was module 1, basic emergency kit. And then this is the continuation of module 1. You can take a screenshot later. And then the module 2, non-critical drugs. So here you've got injectable, non-injectable. This is module 2. Right. So non-critical, not that life-threatening. So anticonvulsant, analgesics, vasopressor, anti-hypoglycemic drugs, corticosteroids. So there's a big list. So what is the alternative also? It's given here. So you should know the alternative also and the regular one also. Then module 3 is advanced cardiac life support drugs. It is at an advanced level. So cardiac life support drugs, so basically related to heart. So for cardiac arrest, adrenaline is there and no alternative for that. You have to keep that adrenaline. So that's why adrenaline is must in any hospital setup. Then anti-dysarrhythmic drugs or bradycardia is there, right? So all this lidocaine and isopropanol, these are the alternative for atropine. Please make a note of this. You have to take screenshots, write it properly, put it on a wall, revision wall, and slowly learn this. And you have to do a detailed study also. Once you learn the name of the drugs, then you should know the classification of that particular drug. Suppose adrenaline, where does adrenaline come? Under which classification it comes? What are the nearby drugs which are alike or same like adrenaline? So like that, slowly, when you do that, you'll have a thorough understanding. And if they twist the MCQ, you are still able to find the correct answer. Then the fourth module is antidotal drugs, where you have got all the antidotes. So opioid antagonists. So you have a nalbuphine over there, which is an alternative to naloxone. Then benzodiazepine, anticholinergic, anti-emergence delirium or vasodilators. So these are the various drugs what is there in module 4. So these are little high-end drugs and given in little serious conditions. Okay, so these are the 4 types of emergency kits, what you can call it. So as I discussed you syncope, so this the major problem is vasovagal syncope. So less blood goes to the brain. So when the less blood goes to the brain, what happens? First, you should know the predisposing factors, why it happens. So this is level 2. I will be telling more about the etiology and the mechanism how it happens. And then alternative medicines I will be telling apart from the regular one. Brief one I have already done in level 1. So the Syncope could be because of psychogenic factors also. The patient is always having fear, fright, anxiety, tension, any exam, viva, anything which the patient is not comfortable and suddenly it comes in front of him, the patient goes into a state of shock and syncope. And there could be non-psychogenic factors also, like the patient has not eaten food for a long period of time, or in one position the patient is in for a very long time, just standing for a longer period of time, suddenly he may fall down also, or completely exhausted, so much work or so much heat is there, patient has just lost his consciousness. And always remember, more than females, males are the ones who go into syncope more if a question comes like that. Because females generally they exhibit their expressions. If they are scared, they may express it. But a male, because of the ego, they may not express this. And because they are not expressing, slowly the pressure is building and vasovagal attack happens and the patient goes into a state of syncope. So syncope has three phases: pre-syncope, syncope, post-syncope, which we all know. So in the pre-syncope stage, there are signs, early signs and the late signs. So in the early signs, suddenly the patient will feel little warm. Over a period of time, loss of color. That means loss of color means the red color, what happened? The blood is going out. Out means it's going towards the extremities in your feet and hand. So other parts it is just reducing and it's going away from the heart. And heavy perspiration is there. Patient tells that he's feeling bad and he can feel nausea also. Blood pressure will be slightly lower at this time and the heart start beating very fast. So this is pre-syncope early stages. And over the late stage, when the patient is already in a state, his eyes becomes almost fixed. So pupillary dilation can be there. The hand, the body which was warm initially, now it becomes cold. And then bradycardia. First it was tachycardia, and at the late stage it is bradycardia. Patient may not be seeing, visual disturbance will be there, and patient will fall down, loss of consciousness. So the basic protocol, which I told you, same, make the patient lie down. So what happens? The blood flow to the brain starts. So there could be anxiety. Because of anxiety, a lot of catecholamines will be released, and that reduces the vascular resistance. And because of that, cooling of the blood at the extremities. So all the blood will be in your legs and hand, extremities of the body. And that much blood is not going towards the heart and the brain. Everyone is going away. What happens? The brain takes a hit. And if the brain does not get a good supply of blood, it stops. So the coordination between the brain and the heart is hampered and the patient goes into a state of syncope. So once the peripheral cooling, the blood is going to the extremities, the heart will say, what is happening? I need to do something. So there is, heart will beat faster. Heart will beat faster, rapid breathing, pallor, perspiration. So it's just a compensatory mechanism to make sure the blood comes in here. Like when you're riding a bike, petrol is less, the engine will make a lot of sound. So that is a statement. Then after trying for a period of time, then the heart gives up and it goes into a state of decompensation. Then the blood pressure which was high, the heart rate which was high, breathing which was high, all becomes low now. So there is reduced blood pressure, reduced cerebral blood flow, and finally the patient collapses. So this is the flow chart, what you should know. So management, syncope, same thing. You have to position the patient, airway, breathing, circulation, you need to start, right? So these are the spirit of ammonia, what you can put it in front of the patient's nose, respiratory stimulant, it will act. And then syncope, head tilt, chin lift you have to do. And then oxygen you should give, monitor the vital signs, and if required, additional procedures needs to be, to be given. Right, so syncope, patient, again I showed you a flow chart. Patient recovers, what you have to do. Patient does not recover, what you need to do. So this is in a dental chair, position the patient, right? So check the level of consciousness, whether the patient is conscious or comatose. You should know that first. So then accordingly, you give the definitive care, oxygen, monitor vital signs. So these are the basic things. Post syncope, if the patient recovers, don't carry on the procedure. Let him be happy for some time. Let him be cool, relaxed, right? Ask the patient choice. Do you want to finish the treatment or not? If not, you can do it on a later time. Next condition, postural hypotension. So this is a condition where the patient is in one state of posture for a longer period of time. And suddenly when he stands up, what happens? He gets giddiness and he falls down because of variation in the blood pressure. Variation in the blood pressure. So postural hypotension is defined as a drop, sudden drop in the blood pressure. That is systolic blood pressure. It falls by 20 mm. And or diastolic blood pressure falls by 10 mm within 3 minutes of standing. So you were sitting, you're lying down for a long period of time. Suddenly, when you stood up, you felt that the earth is rotating, you are getting giddiness. So that is because the blood pressure, systolic blood pressure, went down by 20 mm of Hg and diastolic by 10 mm of Hg. So what is the predisposing factors? Maybe the patient is on many drugs or prolonged period of recumbency or convulsions, is lying down for a longer period of time. Postural reflex is not correct, inadequate. Or in late stage pregnancy, patient is of high age, advanced age, there could be venous defects in the legs, Addison's disease, right? So these are all the conditions what you should know where there could be postural hypotension. So here the clinical criteria for postural hypotension to diagnose it, yes, this is the postural hypotension. So symptoms develop only when the individual stands. When the patient sits down, there is no problem. Only when the patient stands, all this signs and symptoms starts. So on standing, pulse increases by 30 beats per minute. And when the patient is sitting, the pulse decreases. So there is a variation. So that shows that there is a problem. So standing systolic blood pressure decreases at least by 25 mm of Hg. And standing diastolic pressure decreases by 10 mm of Hg. So there is a variation in standing and sitting position. So that shows that there is a problem. So the patient, drug and drug categories which produces postural hypotension. As I told you, patient may be on some drugs. So the drugs could be vasodilators. Patient may be on vasodilators. And because of that, the symptom could have got aggravated. So patient could be on alpha adrenergic receptor agonist or antagonist, beta adrenergic receptor antagonist, central alpha adrenergic receptor agonist. So please learn this. These are the drugs on which the patient may be because of some other problem due to which postural hypotension develops. Then how to manage this? So first and foremost, you have to access the level of consciousness, activate the emergency system, and position the patient supine. Because standing, he will fall down. So let him lie down flat. Don't make him sit flat. Then check airway, breathing, circulation is perfect or not. And then do not panic. Everything will become cool in a period of time. Give good oxygen, right? And after giving oxygen, if the patient recovers, right, slowly make the patient come to its normal position. Then if the patient is still not recovering, then you have to go for basic life support. And after basic life support, patient, if in advanced cases, if he recovers, first of all, basic life support may not be required for this. If it is required and then if he recovers, slowly you can discharge the patient also. So this flowchart, you should know this. Hyperventilation, you have to give carbon dioxide, not oxygen, which I've already told you. So what is hyperventilation? It is defined as ventilation in excess that of required to maintain. There is an excess of ventilation, hyper, that is required to maintain normal blood partial pressure of oxygen and partial or atrial carbon dioxide. More than the normal, it is there. So it could be because of the problems, the manifestations of hyperventilation can affect anywhere in your body. So it can affect the cardiovascular system. So in your heart, there will be palpitations, tachycardia, neurological factors like dizziness, lightness, patient may feel, respiratory shortness of breath, GIT problem, musculoskeletal, and psychological tension, anxiety, nightmares, patient may feel. So these are all the clinical manifestation of hyperventilation. If a patient is always in tension, anxiety, whatever drugs you are giving, not getting corrected, so the patient could be a patient of hyperventilation. So the management, which I've already told in a nutshell, stop the dental procedure, and then you have to check the circulation, airway, breathing, because carbon dioxide you need to give here more. So definitive care you have to do. Whatever materials are there in the mouth during the procedure, take it out, calm the patient, and correction of respiratory alkalosis, right? So your respiratory and metabolic, two conditions are there: respiratory alkalosis, metabolic alkalosis, respiratory acidosis, metabolic acidosis. So that is basically acid-base balance. We need to learn a little more on that. So carbon dioxide you need to give. So hyperventilation, basically Henderson-Hasselbalch equation, on which the equation is, so that is pH is equal to pK divide pK plus log base by acid. So base is bicarbonate and acid is your CO2. So pH is directly proportional to the base, which is bicarbonate, and inversely proportional to the acid, which is CO2, PCO2. So that equation, Henderson-Hasselbalch equation, with that acid-base balance, you can learn very properly. So make a point, you should learn that. Then drug management, if necessary, you can give benzodiazepines, midazolam, diazepam. This is basically to calm the patient. And then you can do the sequence for dental treatment and discharge the patient. So management, which I just told you, you have to correct the alkalosis, respiratory alkalosis. So that is the main point here. In hyperventilation, you can, the problem is recognized, make the patient comfortable, and then calm the patient, correct respiratory alkalosis, and then if the patient is fine, dental care may be continued if it is required, and if both doctor and patient agree. Otherwise, dental treatment you can defer for a next period of time. Next condition, asthma. So asthma is a difficulty in breathing. So what I told you, patient should be in a sitting position. Patient, you should not make them lie down. So asthma can be extrinsic asthma, intrinsic asthma. Intrinsic is non-allergic, idiosyncratic, and non-atopic type of asthma. So the major predisposing factor are stress, antigen-antibody reaction, any reaction which, or anaphylactic, like anything which is allergic, dust, fumes, anything under the sun can be an allergy. So what happens here? So normal bronchial reactivity takes place when if there is the predisposing factors, and heightened bronchial reactivity. So there could be normal or heightened reactivity in the bronchias could be there. And then it can turn out to be an asthma. The difficulty in breathing can come. So signs and symptoms are same thing: wheezing, dyspnea, cough, feeling of chest congestion, tachypnea initially, rising blood pressure, followed by depression. So for anything, there is increase followed by decrease, right? So these are the signs and symptoms, what you should know that. Now, if there is an asthma, you should first categorize it, whether it comes under mild, moderate, severe. So if it is a mild or intermittent, that is not more than 2 months it comes, like every 2 months it is there, or within 2 months only once it has come. So it is mild and intermittent, you can call it. Less than 2 weeks, okay? Basically, 2 times a month. Sorry, what I'm trying to tell you is less than 2 times a month. So in 1 month, 30 days, if less than 2 times, mild intermittent. If it is greater than 2 times a month, it is mild persistent. And if it is every week, you're getting one attack, then moderate persistent type. And if it is very frequent, after any 1 day, 2 day, 3 day, it comes severe persistent. So these are the symptoms of mild, moderate, and severe type of asthma. So this particular column you should know very well. A lot of MCQs can be solved here. So asthmatic patient, make the patient sit. Okay, not patient should not be lying down. So when the patient is sitting, you can give oxygen and bronchodilators can be given. So this is how the patient should do the inhaling, right? So getting ready, first take off the cap off and shake the inhaler. You have to shake the inhaler, and patient should be made to breathe all the way out. Heavy expiration should be there, and then hold your breath and then keep it mouth and then suck it inside. Put the inhaler in the mouth and do not use steroids here. So this is how the training should be given to the patient first who is asthmatic. They should be trained how to give this inhalers, and all the doctors should be aware of all these procedures. It's just not giving an inhaler and say you breathe. It cannot happen like that. You should know what to shake, how, what instructions to be given. Everything is here. So please take a screenshot of this and learn this properly. So management of acute asthma, again same thing, recognize the problem, don't make the patient lie down, make the patient sit, and then give oxygen. And after giving oxygen, bronchodilators, if things are improving, then if required, if patient and doctor both agree, you can continue the procedure, regular procedure, otherwise don't continue. And then you give parenteral administration of the drugs, and hospitalization is required here, right? If after giving oxygen, patient does not recover. So this is the asthma, mild intermittent type. So long time control is not required, which is less than 2 times in a month, 2 times, right? So what you can give is bronchodilators, short acting bronchodilators. And mild persistent one, again, short acting bronchodilators will be of lot of help. Moderate persistent ones, you can give short acting bronchodilators with beta 2 agonist needed for symptoms to control. And severe persistent, again, beta 2 agonist, you can give short acting ones. So these are the different combinations of pharmacological management, what you should know this. Angina pectoris, chest pain across the chest, what I told you. So it could be because of physical activity, cold weather, or your patient ate so much, or there is a lot of caffeine in the diet, right? Fever is there, little cigarette smoking, smog is there, anything, high altitude. So this could aggravate pain in the chest. So then you should know whether which type of angina it is. So whether, first of all, chest pain. So you don't know what is it. So whether it could be angina or not, you have to identify. So it is more likely to be angina if it is the type of pain is dull and there is a lot of pressure in the heart. But if it is sharp and stabbing pain in the heart, it may not be angina. It could be the other reasons. That is your epigastric reasons. If it is the duration is 2 to 5 minutes, then it could be angina. That much 2 to 5 minutes pain will be there, and then it's fine. And again it comes after some time, and again 2 to 5 minutes pain is there. But whereas the other reasons, if seconds, only few seconds the pain is there, seconds or hours, and then it is absolutely fine. So here the onset is gradual, there it is rapid. Location, whether it is reproducible or not with exertion, with the work little more hard. So with exertion, it is reproducible in angina cases. But in non-angina cases, non-heart related, it could be because if you breathe also, it can recover. It can recur. Okay, recur or reoccur. So this chart is extremely important. So please make sure you learn this chart properly. So management of angina pectoris, everything very clear now, right? Position, circulation, A, B, C, airway, breathing, definitive care. So you have to give vasodilators, oxygen, and then if required, medical assistance and vasodilators are always should be given. It's the same thing what I have just told. So now based on frequency of angina, at what pace it is coming. So then ASA physical status, which is we discussed, we know in general anesthesia. So based on the angina pectoris condition, you can put it under ASA classification. So the frequency is if it is 0 to 1 month, angina is coming, then ASA classification, it becomes 2. 2 to 4 months, again 2. 2 to 3 weeks, again 3. 2 to 3 times per week, then ASA classification 3. And if episodes are recurring, then it is ASA classification 4. So based on the type of angina and the frequency of angina, the ASA physical conditions are told here. So please learn this also. Then what are the drugs what we need to give to treat angina? So one is your sublingual nitrate tablet, right? So you should know what is that and what are the other alternatives also. So sublingual nitrate tablet or nitroglycerin, or you can call it sublingual spray, sublingual spray, transdermal pouch. These are all under nitroglycerin. Then you can orally you can give isosorbate dinitrate or isosorbate mononitrate. So these are very important. This flow chart. At duration, you should know 8 hours, 12 to 24 hours is for isosorbate mononitrate. right? So I'm going a little quick because a lot of things are there, but I'm just focusing on the areas where you should not miss out. There is no point in reading everything in detail. For a competitive exam, you should know the areas where the questions can be targeted. The next condition, acute myocardial infarction. So this is basically a problem of the heart. So there is deficiency in coronal arterial blood supply to a region in the heart. The blood is not going properly. So that area, the cell may die. Cellular death can happen and dead and degenerated. Necrosis of that heart, that area can become. So pain will be sometimes very too much, so intolerable pain, prolonged pain, and pain is radiating to the left arm. There could be nausea, vomiting, and the signs could be restlessness, acute distress of the patient. Color of the skin can become pale. Heart rate initially it was more, and slowly it is coming down. Bradycardia it may become. Right. So basically, the management of chest pain again. Any dental treatment is happening, you just discontinue the dental treatment. And then position A, B, C is extremely important. Then if there is a history of angina present, then you have to follow the protocols, right? So that is sublingual nitrate tablet should be ready, nitroglycerin spray should be ready, all those things should be ready before that. If there was no history of angina, so then you have to go step by step. Again, same thing, yeah, basically. First, you should give oxygen, then give aspirin, then see whether the pain is managed or not. If not, check the vital signs and all. And then you can anticipate that this is going to be a sure short case of angina, or you can call out angina, this is myocardial infarction. And then prepare to manage the complications, stabilize the patient, shift the patient, take ECGs, right? And then the medicines I told you, those things you have to add up here. Next is epilepsy. So epilepsy in the patient, it's basically a neurological disorder, and aura is felt around, because of which there's electrical activity of the brain is, what you say, disturbed, and then convulsions or fits can come. So this is the classification of the fits, partial seizures and partial seizures involving the generalized tonic-clonic convulsions. So this you are reading from second videos onwards, a basic classification, you should be knowing this. Localized and generalized. So basically stop the procedure in epilepsy if the dental chair, bite guard or suction can be kept, and then you have to calm the patient. There will be vigorous movements. Make sure the patient does not hurt himself or herself. So basically keep the patient in supine position, right? Hold the patient, and then once the episode goes, if required, you can give diazepam if required, and then you can discharge only after confirmation. So this is what they bring written here also. These are all same things, right? Next is hypoglycemia. So which I have already told in my level 1, hypoglycemia. So hypoglycemia means patient, anyhow, he is going to feel very weak and he may go into the diabetic coma, that means the syncope, right? So this could be, what are other reasons it could be? Potential causes of hypoglycemia. It cannot be only diabetic. Major reason is diabetic, but other symptoms the patient is having or the syndromes the patient is having. So because of the secondary factors, because of the secondary impact, or to say the impact or the secondary factors, there could be hypoglycemia. So Addison disease or active fruit if the patient is eating, so because of that it can happen, right? Hyperthyroidism, or it could be hypothyroidism, the patient insulin is not proper, malfunctioning of this cells, malnutrition, old age, anything can be a factor because of which the patient can go into hypoglycemia. So this hypoglycemia is, again, the manifestations are early, more severe and late severe stage. So early stage, basically the cerebral function will be disturbed, change in mood swings will be there, and hunger and nausea will come. Then over a period of time, when the patient goes into the next stage, patient starts sweating. That is more severe stage, sweating, tachycardia, increased anxiety, and patient will be uncooperative. And in the later stage, The vibration starts, that is unconsciousness, seizure activity will start, patient blood pressure may go down, and the body may become very cool also. Hypothermia can happen. So you have to identify the patient based on this flow chart, at what stage, what is happening, and then you have to make sure the patient is calm, quiet, and then you have to give carbohydrates. That is the dextrose. You have to give carbohydrates, IV, 25% dextrose, you can give that. That is the management of hypoglycemia. Next is adrenal crisis. So the patient will be on steroids. You have to double the dose before any procedure. So criteria for determination of adrenal insufficiency. So that means the predisposing factors. History of current or long-term steroid use. Patient is taking long-term steroid and suddenly discontinued. That patient can be a potential to go into adrenal crisis. That's why case history is extremely important. Then nausea, vomiting, abdominal pain, hypotension. Patient is telling, sir, I'm a patient of hypotension. Patient can go into a state of adrenal crisis. So here, same thing. Your emergency kit should be activated. It should be ready. You have to make sure oxygen is there, right? And then your glucocorticosteroids is there, right? And if required, IV access line also needs to be stimulated. So it's the same thing what I told. The presentation is different. It's shown in a table format, but the meaning remains the same. So double the dose and make sure the steroids are ready. That is, hydrocorticosteroids are ready. Next is anaphylaxis. So there is a severe reaction, hypersensitivity reaction. So hypersensitivity reactions are 4 types, right? ACID. A for anaphylactic, cytotoxic, immune complex, and the delayed type. So based on the type, the time of reaction, you can brand it as, if it is seconds to minutes, the reaction starts. So it is very fast, it has come. So that is anaphylactic reactions. And then 6 to 8 hours after that, you get an allergic reaction, that is immune complex. And after 2 days, if a reaction is happening, that is called delayed or cell mediated. So this is the time frame what you should know. This can come as an MCQ also. And the examples of all these anaphylactic reactions, any drug or urticaria, angioedema, or hay fever, are the potential scenarios where it could be an anaphylactic reaction. And the anaphylactic reaction could be drug induced also, because of any drug, patient can get anaphylactic reaction. So the most common ones are antibiotics, penicillin, cephalosporins, analgesics, opioids. So take a screenshot of this. This could be a potential MCQ question. So there could be skin reactions, urticaria, angioedema, rhinitis. So that reaction can develop very fast and it can be life-threatening also. So please remember, bronchospasm can also happen. So anaphylaxis, immediately adrenaline has to be given. 1:1000 is the concentration. So these are the conditions how you have to manage. Then coming to the next condition, LA toxicity. So you are going to do a case, you don't know whether the patient was allergic to amide or ester. You just gave an LA and suddenly the patient has developed allergy. This is for unknown cases. If it is a known case, patient himself is telling prior, sir, I am allergic to LA. Okay, so when you know that he is allergic to LA, so give him antihistamines. Make sure the mast cell stabilizers, everything is under control and there is no reaction. So what is antihistamine? The normal tablets what you take for your cold, common cold, Allegra, Cold Act. So many tablets are there, antihistamines, right? You can take this, give to the patient. And then this is for the known case, right? So who are the patients who may get LA toxicity? Predisposing factors, right? Under 6 years of age. So you give little LA, the dose can become very high for them. Under 6 years or over 65 years. So the dose variations can happen because the blood supply may be little less in above 65 years old patient. And body weight also. Lower body weight increases risk of patient getting into LA toxicity. So weight of the person is also important. And if the patient is having liver disease, congenital heart diseases, pulmonary diseases, congestive heart diseases, that could be a reason for getting LA toxicity. And drug factors also, if the patient is taking combination of drugs, if he's on a drugs which are vasodilating, there could be increased risk. If the dose of the medicine is very high, again, the route of administration. So many factors are there. So please be informed that it's not only the dose, the other factors are also responsible for getting LA toxicity. So how the LA toxicity? You may, a patient was very calm, you gave LA, suddenly the patient starts talking more and patient is confused, talkative. He becomes very excited. His speech becomes abnormal. He slutters, right? Blood pressure becomes elevated, heart rate. So that means some changes are happening in the patient. So this is because of low to moderate overdose, these changes will happen. Then in the blood levels also, the LA, how much concentration is the blood, then there is effect on CVS and there is effect on central nervous systems also. Patient may get headache, light headness, dizziness will be there, blurred vision, ringing sounds in the ear can happen, drowsiness, disorientation, and this is what I was talking about. So these values are very important. So cardiovascular system, if in the blood 1.8 to up to from 0.0 to 1.8, that is normal. If concentration in the blood, microgram per ml, this much concentration is there, it's okay. 1.8 to 5 microgram per ml, there will be anti-dysrhythmic action, CVS effect. Then from 5 to 10, ECG alterations will happen. Myocardial depression will happen. And 10 plus, there will be massive peripheral vasodilation. Similarly, in central nervous system, right, from 0 to 0.5 or 0.4 normal, 0.5 to 4 anticonvulsant action, and 0.5 to 7 you have got CNS depressions, then 10 plus generalized CNS depression. So this is what the most important LA toxicity, you should learn this. So here calm the patient, make sure the patient is out of this and then only you discharge the patient. Hemorrhage, again, clotting factors could be a problem or some secondaries could be there in the patient, right? So basically, you should have know the mechanical method, pressure, hemostat, sutures, ligation, chemical methods like adrenaline. You can, in LA bottle, in the LA, there will be adrenaline, or if you have vial of adrenaline, put it in a gauge piece and keep it on the socket. Thrombin, Surgicel, Oxycel, gelatin sponge. So these are all different chemical methods by which you sprinkle there, you keep it near the socket, mixed in a gauge piece. All these things will really help, right? Surgicel you can pack inside the socket and tighten it. Bone wax is also there. So thermal agents like cautery. So you can take the cautery, the electrodes, you can bring it towards the source of bleeding, and then you can arrest the bleeding also. If the cautery is not available, then you have got ball burnisher, your normal amalgam filling instruments and your endo fillings, you have ball burnishers, right? So ball burnisher, you can heat it and that can also act like a cautery only. So cryosurgeries can be done, lasers can also be used to arrest the bleeding. Then if there is a hematoma, direct pressure over the site of bleeding for a few minutes if you apply, that is the only solution for this. Over a period of time, gradually it goes, right? If so much concern is there, analgesic antibiotics, otherwise there is not much required. Over a period of 14 days only, this hematoma will go. Foreign body aspiration, Helmicks maneuver, I told you 5 beats, you have to beat like that. And on the epigastric region, you need to give 5 thrust and all. So Magel's forceps. With the Magel's forceps, you will Magel's intubation tube. This is what they ask in the MCQs. Foreign body aspiration, which instrument is used to take it out? That is Magel's intubation forceps through which you take the foreign body out. Okay, so dear students, these are the ones what you should know. These are the few conditions. I know that in a single class, in 1 hour, the entire medical emergencies cannot be covered. But if you are there in the class and you heard everything, so you'll come to know an idea how to read, what to read, and which all the areas we need to focus. Because it's a competitive examination, it's not important you should know each and every minute details, but you should know the potential areas where MCQs are asked. So whenever doubt, see this class again and again, go back to your textbooks and do a retrograde study also, right? So with that retrograde study, like pharmacology, little bit of medicine, biochemistry values, when you see, things will be much more clearer. 2 times, 3 times once you do, you will be in a position to take a judgment and then you can derive to the answer. Okay, so do lot of MCQs. And any doubts, any queries, please put it in the our WhatsApp numbers are there, chat box is there. Please put it. Me and my team will be at your service to make sure to help you out there. Okay, so thank you so much.